Welcome back for another 30 minutes of ACOEP Virtual Scientific Assembly. Caitlin and I are joined now by Dr. Scott Leucten. He's currently the program director of the St. Barnabas Hospital in the Bronx, or St. Barnes if you're from around the area. I'm currently in Florida, but we have some St. Barnes grads at my hospital, so always good to get somebody from the inner city. He's going to be giving us a great review on some orthopedic injuries, particularly in patients who present with hip pain or diseases of the hip. So Scott, we're just going to kick it over to you and you can take it away.
We're going to talk about the hips, all in the hips. We have no financial disclosures, and our goals and objectives are today to talk about the different areas of the hip fracture and associated risks, discuss timing of repair, hip dislocations, and the science behind blocks for these patients. The first key is that this is a big problem. And we know this is a big problem because you're seeing this every single day in your practice. Over 300 or close to 350,000 people a year will get a hip fracture. Worldwide, the rate of hip fractures is approximately 150 per 100,000 people in North America. And the mortality is high. Reported overall mortality of hip fractures is 15 to 20%. Yet in older patients, this can increase to close to 36% over the year following their hip fracture. So this is not just a problem today. This is going to be a problem for them going forward. The rate of mortality is greatest in the first few months following the injury, but remains high up to a year after the fracture. And that's from the complications of inability to walk, infections, DVT risks, and other things like that. And the other stat that I found quite interesting is that only about 65 to 70% of patients will regain their pre-fracture ambulatory status. And so this is a major impact for them going forward, even if they survive this injury. So let's start at the very beginning. It's a good place to start. And this is going to be your basic Apview X-ray. And so different areas and different things you're looking at, because of course you look at the pelvis, but when we get to the hip itself, you're looking at the joint space, the femoral head and how it works with the acetabulum, the greater trochanter and the lesser trochanter, and the femoral cortex of the bone itself. The other important thing I want to bring to your attention is called Shenton's line. And it's a line that you draw through the inferior aspect of the superior ramus and the medial aspect of the upper femur. And you can see here it's nice and smooth. It should describe a smooth curve. If there's any sharp angulation of Shenton's line, the patient could have a neck of the femur fracture. Any abnormal Shenton's line can be the most obvious indicator of a patient's fractured neck on the AP view. And so most of the time these fractures may be obvious, but sometimes, or the dislocation may be obvious, but it's not a bad practice to look at Shenton's line and make sure it's smooth on both sides throughout. And then here we have an example of obviously a incomplete Shenton's line or a big angulation off that, representing a dislocation. It looks like also a fracture in the head of the femur here. Just a note about X-ray and technique, and this, I know this is not us, but there is some, we just want to also make sure that there's some technique involved. And so when you're seeing these patients, you're seeing their X-rays, you want to make sure you're seeing everything. If the patient's legs are externally rotated too much, the greater trochanter on top here is partially superimposed over the femoral neck, maybe not giving you a perfect X-ray. When the patient's legs are internally rotated, there's a maximum visualization of the femoral neck. And just, internal rotation of the legs too much. So if we bring those in too much, it can be overdone, and you can lose the lesser trochanter here. So as you know, more views are better. I'll be showing mostly only one views for my presentation, AP, but the lateral view, also known as the frog leg lateral view, may show some displacement. Most places will not recommend those on traumatic patients in the trauma bay or the suite when you first get there. CTs of the fractures also may be necessary. We'll briefly just touch base on this, just in the vascular supply to the femoral head and neck, because it's important later when we talk about avascular necrosis and complications possibly of these hip fractures and even these dislocations. So the main vascular supply of the femoral head and neck is the medial femoral circumflex artery and the inferior gluteal artery. And so it comes from the deep femoral artery. And again, this will play a role when we talk about avascular necrosis. As you can see, it's a distal to proximal blood flow to the femoral head and neck, and that, if that's disrupted, can lead to avascular necrosis later on. So there's kind of 4 different areas that the femur can fracture, and they all have their own unique kind of presentations, concerns, and worries. And so we're going to go over each kind of different area in detail just because, again, each one can present differently and will have different complications associated with it. So we have the femoral head, the femoral neck, the intertrochanter area, and the subtrochanteric area. Those are the 4 different areas that we are concerned about. So the first is the femur head. A fracture of just the femur head is actually rare. So these will most likely present with a dislocation. So in this X-ray, we have an isolated fracture, but this will, again, dislocation is going to be your practice here. So on physical, a posterior dislocation is obviously most common, aka dashboard injury, and obviously the extremity appears adducted and internally rotated with anterior dislocation. With anterior dislocation, the extremity is abducted and externally rotated. And so let's jump into that rabbit hole right here and talk about dislocations. Our first dislocation, most common, is our posterior dislocation. That's going to be about 90% of the time. The classification goes from simple to complex. A simple dislocation will not have a fracture associated with it. A complex fracture will have either an acetabular or a femoral head fracture associated with it. Posterior dislocations occur with a lot of axial load on the femur, typically with the hip flexed and adducted. And so this is your common dashboard injury. Position of the hip also determines whether or not there's associated acetabular fractures, increasing flexion. Increasing flexion and adduction confers a simple dislocation. If there's more extension involved, it can have a fracture. On X-ray for your posterior dislocations, the femoral head appears smaller than the contralateral femoral head. The femoral head superimposes on the roof of the acetabulum. And there's decreased visualization of the lesser trochanter to internal rotation of the femur. And so you can't even see the lesser trochanter here on this dislocation. They're going to recommend that post-reduction of these, and we'll get to the reduction techniques in a second, post-reduction CT or X-ray should be performed on all traumatic hip dislocations. Why? Because they're generally associated with femoral head fractures, loose body, and then also your acetabular fractures. And so after you reduce this dislocation, you want to look for those fractures that may be present. Again, a femoral head fracture in itself is very rare. So this is going to be your picture of your anterior dislocation. Again, about 10% of the time. In the traumatic setting, the hip is forced into abduction and external rotation of the thigh and is often related to, again, motor vehicle accidents or falls. On X-ray, your femoral head looks larger than the contralateral femoral head, and the femoral head is medial or inferior to the acetabulum, which will be a key to dislocation. Let's take a minute to talk about timing. So this slide is not broken. I want to get across to you 6. Why just the number 6? Well, in dislocations, that's the time we need to get them back in. Disruption of the femoral neurovascular bundle and blood supply to the femoral head places patients with hip dislocation at risk for femoral head avascular necrosis. At the 6-hour mark, so patients with a delay in hip reduction of greater than 6 hours have a much higher relative risk of avascular necrosis. From one of the famous studies, I think it's actually before even 2000, it's looked at 4.8% of avascular necrosis less than 6 hours, 52.9% after 6 hours. And so, again, we want to get these hips back in as soon as possible. Post-traumatic arthritis is also a phenomenon, and that can occur up to 20 patients following a single traumatic dislocation and can be a source of chronic pain. Your prosthetic hip. Most common actually in the first month since the replacement. I get a lot of questions and a lot of debate about whether or not orthopedics is needed in replacement of these prosthetic hips. Multiple studies have shown that we can do this in the ED safely, and we do it quickly, and so that's important. I'll show you some of those studies in just a second. Just to give, again, I asked some of my faculty, and I was surprised that some faculty always call orthopedics for these, but these are well in our realm of replacement. Multiple studies have shown that ED can do this safely. Patient-specific risk factors for displacement includes advanced age, neurological disease, and impaired compliance. So again, this will happen to 1 to 3% of patients with prosthetic hips. 70% of these are going to occur within the first month, and still the vast majority of these will be posterior. And actually, might report activities, simple activities that displaced these hips. And so similar activities may just be shoe tying or sitting in a low seat or toilet, and as they raise, they can dislocate their prosthetic hip. Again, 70% in the first month, they'll still be posterior, and this is pretty common to those. So this is a smorgasbord of different studies showing that ER docs, even back from 2005, can be doing this in the ED. When do you want to get orthopedics involved is when you can't get it back in, right? As we talked about, even though avascular necrosis is not as much of a concern in patients with prosthetic hips, you still want to get these in. So if you can't get those in, if there's some fractures of the acetabulum or there's some loose bodies, that may be time to get orthopedics involved. So how do we get that back in? How do we get that back in? First, likely we're going to need some sedation, right? So we're going to need some sedation. Procedural sedation is probably indicated in the majority of these patients. The first method, to your left of your screen, was described as Captain Morgan method. That was described back in Annals in 2011, so 10 years ago, based on the character, and it's based obviously on the character of the spirit bottle. The patient lies supine with an assistant stabilizing the pelvis. You place your foot on the patient's bed with your knee flexed in a position behind the patient's knee. You're going to place one hand under the patient's distal thigh, and the other one on the patient's ankle. And again, the upward force to the hip is generated by your knee, while your hand on the ankle maintains a gentle, constant downward force. Just keep in mind that the majority of your force should be created with your calf rising upward, bring the hip back in, and not from the ankle. The other techniques, a couple other techniques, we'll just quickly mention here, is the Alice maneuver. The Alice maneuver is similar, kind of, but you're going to hold the leg just below the knee, which should be flexed about 90 degrees. Traction is implied in line with the femur. And as the hip begins to reduce, you're going to gradually extend it and externally rotate the hip to facilitate reduction. And the final method that I have down here is the Bigelow method, or Bigelow maneuver, excuse me. You're going to place the patient in supine position with the physician beside the bed. You're going to place your forearm beneath the patient's knee and grasp the ankle with your opposite hand as shown. When the assistant stabilizes the pelvis, flex the hip to 90 degrees and apply traction in line with the femur. Again, externally rotating, extending the hip until reduced. For anterior dislocations, you're going to basically just you're going to do the Alice maneuver, but just different forces, right? So the patient's going to be supine again. You're going to be on the bed or beside it, and then when the assistant stabilizes the pelvis, the surgeon or the ER doc grabs the ipsilateral leg at the knee and applies traction in line with the deformity. And then you'll also most likely have to adduct, externally rotate, and flex. There's no associated fracture associated with these dislocations. Generally, full weight bearing is tolerated and might be indicated. Associated fracture depends on surgical or non-surgical management by orthopedics. And again, you want to get ortho involved when there's irreducible dislocations, evidence of incarcerated fractures, unstable fracture dislocation, and a delayed presentation, or if the reduction is not concentric. And so that's going to be your femoral head, most likely associated with your dislocations. Let's move to the femoral neck, which is very common for fractures. The patient presentation of the leg may vary based on the type of the fracture, right? In significant fractures, the extremity is going to be slightly shortened, abducted, and externally rotated. And with a stress fracture or severe impaction fractures, the only physical finding may be just pain. And there's no limitation of motion. So don't be concerned. Don't not be concerned if you don't necessarily see the classic shortened leg. There's a classification of neck fractures. It's called the Garden classification. It's simply tries to predict the development of avascular necrosis again. So as we go, we're worried about avascular necrosis with the head. We're also worried about avascular necrosis with the neck. Type 1 and 2 will be non-displaced, while Garden 3 and 4 are complete fractures with some form of displacement. Just be careful about relying too much on this, even though orthopedics will generally pick this classification system to classify them. Only 40% in one study believe that they could differentiate between the 4 types of fractures in this classification. Also, some concerns in this classification is that patients with Garden type 1 and type 2 still had 23% and 38% complication rates with a reoperation rate of 30%. So there can still be severe complications for these patients, even if we're only in the Garden 1 or 2. And so this is going to be a type 3. If you're looking at this as a type 3, you can see some dislocation, but it's not completely dislocated. And so this is going to be a type 3 Gardner classification. Timing. Let's talk about timing because this is really important. This was a study from JEMA in 2017. There's been some follow-up from this, and we'll get to that in a second. And it talks about association between wait time and 30-day mortality in adults undergoing hip fracture surgery. Again, this is an observational study. So this is an observation study, so you can't make a direct correlation. But observation studies suggest that delays to operative fixation of hip fractures are associated with a higher 30-day mortality and increased morbidity, including PEs, MIs, and pneumonia. And so they were arguing that the 48 hours is when you might get into operate on these. In fact, a recent study, and this was the hip attack study, and this was recently done out of Canada, and it was a random controls trial, and they looked at accelerated care, which they determined as time to the OR less than 6 hours, versus usual care, which was about 24 hours. And though it showed no mortality benefits, it did show a lower rate of delirium and decreased rates of stroke, infection, and UTI. So again, there was no difference in mortality here, but there was improvement in some of these other comorbs that come associated with hip fractures. Again, this was also comparing only 6 hours versus 24 hours. And so in our role as ER physicians, it's not just to find the fracture, but it's also to get them to the right spots and getting ortho involved early. They might need medical clearance. There might be associated trauma with these patients. And so therefore, it's really important for us to get these patients into and to do anything to get these patients to the OR quicker. It'll be better for them long term. Trochanter fractures, right, will happen between the greater and lesser trochanter. Its incidence is common, roughly the same as the femoral neck fractures. Generally, it's very female to male. The ratio is 4 or 5 to 1, females to males. The typical age of these patients will actually be older than patients with femoral neck fractures because it does to cause this kind of much damage will need more osteoporosis and brittle bones. Risk factors include the elderly, osteoporosis, but also proximal humerus fractures increase the risk of hip fractures for 1 year. So patients with those proximal humerus fractures have an increased risk of hip fractures in that next year, and so that might be a risk factor for these type of fractures. The extremity will appear shortened and significantly externally rotated. In contrast to the minimal deformities associated with the femoral neck fractures, you'll see significant rotation and shortening here. There'll also, of course, be pain, hip edema, and ecchymosis, and pain with any movement will be noted. This is the one kind of intertrochanter fracture because this is a fracture of just the isolated greater trochanter, and these actually may not need the OR. The vast majority of intertrochanter fractures will, but if it's an isolated here, you see it on the left, they likely won't need an operation. Then there's subtrochanteric fractures. So this will happen below the areas of the trochanters. It's also common. It's 7 to 34% of femur fractures. The proximal femur is usually held in flexion and external rotation. These are all basically going to the OR. There's 3 different classifications for these. Type 1 occurs at the level of the lesser trochanter. Type 2 occurs within 2.5 centimeters below the lesser trochanter, and type 3 will happen below that 2.5. We talked about earlier that there's concern for avascular necrosis. We were really worried about the femoral head. We were really worried about the femoral neck. Not as worried with the intertrochanter fractures. Subtrochanter fractures, we're not worried here about avascular necrosis, but we are going to be worried about significant hemorrhage. And so significant hemorrhage is common with these type of fractures. IV resuscitation, blood products are frequently necessary, and ED application of traction or traction splint is necessary for these fractures as we stabilize these patients. So again, more proximal, we'll talk about this with avascular necrosis. More proximal, we're worried about avascular necrosis. More distally, we're going to be worried about bleeding. I can't see it on X-ray. This is quite common. A study from the Journal of Radiology in 2020 looked at this, and they concluded occult hip fractures are common. Up to 39 patients between the ages of 56 and 82 with suspected hip fracture were not seen on X-ray. They recommend MRI is better than CT, But I would just urge, don't forget about that time. We talked about the need to recognize these quick. And so we want to recognize that. So if MRI is not easily available for you, CT may be the way to go. And the way not to miss these, of course, is to make them walk, right? Make them walk in the ED to gauge whether or not, if they can't walk, then we have concern about a possible hip X-ray, especially in falls. This is a quick test that I've learned from a couple of people, the timed up and go test. It's really quick to do in the ED. Basically, you have an elderly patient, they get up, you have them get up from sitting, walk 10 feet and then back, and you time how long they can do it. And greater than 12 to 15 seconds is concerning. And if they can't do it, obviously, we know we have concern about a possible hip pathology. Avascular necrosis, again, we've talked about this a little bit. These are not all trauma related. There's multiple diseases that can cause avascular necrosis. But again, as we get closer to the head of the femur, we have greater risks. So a subcapital femoral neck fracture can have almost a 50% risk of avascular necrosis. And then when you get down to the intertrochanter region, you're looking at about 10% risk. Again, early recognition, early treatment, and getting them to ortho is going to help you with that. And then it's associated with a dislocation. Bring that hip back in quicker, the better. A quick talk about nerve blocks. And so this is out there, and hopefully you are using these. It's not going to go over how to do them, but that this is really useful. It saves on opiates, and it's effective. So one of the best review articles, this was 2015, it looked at 9 random control trials, and that showed that regional nerve blocks were equal or superior in reducing pain scores compared to standard treatment, required less opiate use, and led to no life-threatening complications. There was some increase in minor complications, such as LAST, or local anesthetic systemic toxicity, and nerve damage. But again, those were the rate of LAST that they found was between 8 and 30 at 100,000, and for nerve damage, it's 2 to 30 over 100,000. And most of those resulting symptoms resolved over several months. And so, if you're not using these commonly in your shop, look into these. I had a patient last week with a hip fracture. We had the ultrasound team come over. They did it. It worked out really well. So regional nerve blocks for hip and femoral fractures have a benefit in reducing pain and the need for IV opiates, and looking to be using these more and more. And conclusions. So we talked about the different areas. We talked about the femoral head, neck, the intertrochanter and the subtrochanter area. We worried about the concerns that we have for each of them. Again, the more proximal you are, you have concern for avascular necrosis. And the more distal you are, especially in the subtrochanteric hip fractures, we're more worried about hemorrhage. Time is important. More and more studies are showing the faster that the orthopedics can get to them to the OR for their definitive treatment, whether it's a hip fracture, the better. With dislocations, your risk of avascular necrosis goes up after 6 hours of being out. So you want to get those patients out, you want those hips back in, and them out of your department. And don't forget, we have to find these, right? These are you can't miss kind of things. If you're concerned, you can look at your x-rays, make sure your x-rays are high quality. If not, then you go to preferably MRI, but also CT might be a suitable option for those patients who can't walk in your ED. So walk your patients and find these and look for them. I appreciate the opportunity, and thank you for joining us.
Well, Scott, we really appreciate you coming on and talking about this particular problem. I love that you brought up walking your patients. It's odd that that is one of the first things that my trainees forget to do for these elderly patients who have hip pain is walk them. When you talk about MRI or CAT scan, if somebody was to get a CAT scan, what particular CAT scan would you tell them to go for?
I think part of it depends on the mechanism. Correct. So if you're concerned about a fall, you probably want to include your pelvis in there. So you might want a CT pelvis, right? Maybe abdomen, depending on where you kind of are. That will get the majority of your neck fractures, which is the ones mostly missed. If you're just worried about if it's more of just a hip pain without the necessary isolated trauma, it may just be a CT of the hip. But I think the majority of CTs I will order will be pelvis, because I get the pelvis in there too. You might miss an acetabular fracture that might be causing similar pain.
Nice. And then let's say we get this patient, we find them, and then we have to hold on to them. You mentioned acute pain management. What's some other, like maybe longer term pain management patients? Somebody we're going to hold in that apartment for a couple hours. And I only bring that up knowing that that's now the normal post-COVID or with COVID.
Yeah, no, absolutely. I mean, I've had very good success with the nerve blocks, giving multiple hours that way. We also debate in our department, at least I don't know about others, about maybe lidocaine patches as well can give some anesthetic as that way. And again, some traction can help, right? Especially if you have a big displacement there, getting traction can give those patients pain. And then if you do have to use opiates, you may have to go there. I know as we trend away from those, but those are some of the pain management techniques that I'll be using.
Yeah, I love the block. Is that an ultrasound guided block in your department, or is that anatomical?
The majority, yes. The majority are ultrasound guided blocks, correct.
Yeah. Yeah, we could have a whole nother talk just on ultrasound guided blocks. I think.
Exactly. I don't want to go into. I am not nearly knowledgeable enough about it to teach it, but I found them incredibly useful as we've kind of brought them into our department more and more from our ultrasound division, which is fantastic. And so they will generally do them on ultrasound guided again to avoid that artery, or obviously the vein as well, but more the artery, and then also the nerve itself as well.
Yeah, nice. All right. Well, Scott, there's no other questions in the chat, so we really appreciate you hopping on, and we look forward to seeing everybody at the next session.
Thank you, everybody.